Well, good afternoon, everybody, and welcome, whether you're here in person or watching the live stream. It's really great to see so many people here today. Thanks for coming. It's very exciting for us to be able to host today's guest lecturer in Swansea today, and even more so as this lecture has been designated as RCPath's eponymous Kettle Lecture for 2024. It's an annual memorial lecture named after Professor Edgar Kettle, who you can see here, FRS, and it's particularly apt for this lecture to take place in Wales because Professor Kettle was Professor of Pathology at what was then known as the University College of South Wales in Cardiff between 1924 and 1927. Edgar Kettle studied medicine at St Mary's Hospital in London, graduating in 1907. And in 1924, he was appointed Professor of Pathology in Cardiff, where he established a centre of teaching and research in pathology. He developed a special interest in silicosis and tubercular infection, which, of course, he was perfectly placed to gain experience in that during his time at Cardiff, and able to show experimentally that silica lesions acted as a nidus for tuberculous infection. He then went on to London again as professor at St Bart's Medical School. He was on the MRC's Industrial Pulmonary Disease Committee and Radiology Committee. He was president of the pathological sections of the BMA and of the Royal Society of Medicine, before he was elected Fellow of the Royal Society in 1936, just very shortly before his death. While his close colleague, Dr. James Murray, noted in an obituary that he inevitably organisation and administration occupied much of his time and tried his qualities of tact and courtesy to the limit. He was all the same fondly remembered as a gifted teacher and experimental researcher who was noted to be particularly dedicated to developing his junior colleagues. So it's now my pleasure, having explained the background to the Kettle Lecture, to hand over to Sharon Poynton, who's going to introduce this year's Kettle Lecturer. Thanks, Sharon.
Good afternoon. Professor Peter Chiodini is consultant parasitologist at the Hospital for Tropical Diseases, honorary professor at the London School of Hygiene and Tropical Medicine, honorary clinical professor at University College London, and director of the UK HSA Malaria Reference Laboratory and Parasitology Reference Laboratory. He organises the UK Nequus Parasitology, is a member of the UK HSA Advisory Committee on Malaria Prevention in Travellers, the Department of Health Advisory Committee on Dangerous Pathogens, and advises the National Blood Service on the prevention of transfusion-transmitted parasitic infections. He is an ESCMID Fellow and was Dean of the Faculty of Travel Medicine of the Royal College of Physicians and Surgeons of Glasgow from 2009 to 2012. He is also a practicing clinician at the Hospital for Tropical Diseases, with special interest in malaria and hydatid disease. His research interests include new diagnostic methods for parasitic infections, malaria, Chagas disease, and hydatid disease. In 2018, he was awarded an OBE for services to parasitology and malaria. Please join me in welcoming Professor Peter Chiodini to Swansea.
Thank you very much indeed. Before I start, I just should say how this came about. So last November, I was kind of minding my own business in the tea break at the NICWAS meeting of microbiology, and I was buttonholed, cornered by Sharon, who said, "Oh, would you come and give us the lunchtime lecture in Swansea?" I said, "Yeah, of course, that's fine, no problem." And then it's become an eponymous lecture, so thank you very much for that. That's really good. And this is a big deal. Eponymous lectures are a really big deal. We've got a giant of pathology there in the years when there wasn't a Royal College of Pathologists. He was a fellow of the Royal College of Physicians. FRS speaks for itself. They don't hand those out with the rations. But most of all, note the beautiful waistcoat, which are now back in fashion. And he would have done very well in today's community wearing a suit like that. So good on him, and I hope I can do him a bit of justice with this talk. So I have had to cover in my career pretty well every parasite except for Toxoplasma lab diagnosis, which is the references here, as you know. And so I've had to encounter anything from 6-meter long tapeworms down to microsporidia, which we've now had to hand over to the mycologists, unfortunately, that are really very tiny indeed. So had to cover a great deal of territory. So we're now going to move on and look at my background first of all, and then some hardcore science. I don't work for them, and I'm not asking you to give them money, but please support the ethos of the Social Mobility Foundation. The Social Mobility Foundation was founded to help working class children, or those who were eligible for free school meals, parents who had never been to universities, poor families basically, get into the professions. There are only 6 or 7% of doctors come from working class background, and I'm one of them. So my mission is to try and improve that. And I'll tell you a bit about my backstory, and then we'll go on to the science. So until I was 8, I lived in London. And when I walked to school, you could walk to school then at the age of 8, in Tottenham, I would look up on the hill would be Alexandra Palace. And on the top there was a light, which I thought meant they were broadcasting, but of course it was to warn low-flying aircraft. It was blissful, lovely school, lovely area, so far so good. And the nearest tube was Turnpike Lane. But my father worked in the hat trade, and after the Second World War, felt hats weren't worn. You see them in the old movies, but how many people wear felt hats now? So from the late 40s onwards, it was just a downward graph of trade in the hat trade. So his job moved from London to a small provincial town, and the wages in the hat trade were low. The business failed because people weren't buying hats anymore. So he had to take a job as a machine operator, and my mum got a job as an assistant cook in a local department store. It was pretty grim, not the town, but not having a lot of money. And also, the town had one bookshop. Can you imagine one bookshop? There was no Amazon. You couldn't just get them online. It didn't exist. So I'd go in and I'd say, oh no, we haven't got those. You'll have to go for London for that. And so I was absolutely distraught. And I'd still talk about it. My wife said, you need counselling for this. And she's probably right. But, and this is not a political statement, there was a grammar school. And I'm not advocating whether we keep them or we don't keep them. But they, plus my parents encouraged me to get everything I could from the education system, saved me. And then that's how it all came about. So what did or does a clinical parasitologist do? Well, you already heard that really from Sharon, so I'm not going to go in that. But I bridge both pathology and clinical medicine. So I'm fully signed up as a physician and as a pathologist. Now, when I started that job, that wasn't very common. And then the clinical haematologist came along, and now we've got combined training for micro, which is the best thing ever, I think, because it has to be brought together. It shouldn't be a divide. Now, I was single-handed for the first 29 years as the national parasitologist, from a senior registrar one day to the national or world authority the next. Big jump, you know, in at the deep end. And I remember in the first few years, Dave Warhurst, who some of you will know, who's sadly no longer with us, was our clinical scientist. We had this very difficult case, and we looked at each other, and then David said to me, well, there's no one else we can ask. And that's true. When you're a national expert and there's one of you, there's not much else you can do. So I got to know most microbiologists by their phone voice. I never met a lot of them, but I knew, oh, this is somebody from Darlington, because I know his or her voice. And now there are rather more, as you'll see later. So it was a big jump. Now, you'll all be familiar with this quote, which is often quoted at pathology meetings, saying, as is our pathology, so is our practice. That's Sir William Osler. But what I didn't know till I researched for this lecture is there was another bit on the end of that sentence. Now, that these days would be inflammatory. What he should have said was what the pathologist reports today, rather than thinks the physician acts on tomorrow. And that was in the days when really physicians thought pathologists were their servants, and you'd get this awful, what are you doing coming near the patient stuff, which doesn't happen much now, but there's still a bit of it. So Osler was right, but I think he probably could have phrased it in a less inflammatory way. And I always find it amusing to see how this works in practice. So I'll be in the lab, look down the microscope, diagnose malaria, leishmaniasis, whatever it is, echinococcus. I go and do a ward round. Oh, Mr. So-and-so, you've got visceral leishmaniasis. So we're going to give you some ambisome. You'll be out in about 3 days. Oh, thank you very much, doctor. And you go into the next bed. What I should have said was, well, one of my BMSs did the bone marrow smear. They stained it up, looked at it, said, look, Prof, there's some leishmania in here. I said, yes, yes, there is. But then what happens, they leave the ward. It's whiskey for the doctors and it's chocolates for the nurses, which the doctors, that's a male hand, then steal as they go around doing the ward round. And my wife, when she ran a ward, stopped that. She got the box of chocolates, locked them in her cupboard, and every so often would give one to each of the nurses who'd earned the chocolates, and the doctors lost a bit of weight as a result. Now, we're going to be talking about life cycles. So the Lion King, this is the Lyceum in London. You see the address there and the circle of life. Hands up those of you who've seen the Lion King. Yeah, okay, yeah, most of you, either the movie or the show. Well, I went one further than that because a family friend of ours played Pumbaa for 12 years. So this is me in my Pumbaa outfit, and you can actually, you can open his mouth and wiggle his tongue with one hand, and with the other hand, you can wiggle his nose. So good old Keith Bookman, who was Pumbaa at that time, kindly let me dress up in the costume. It's quite a heavy costume. You have to be quite fit, and he let me off having to wear the hoofs and so on. But so we're going to be talking about life cycles because they are the basis of all parasitology, really. Now, we're going to focus on just the red circle on this. Very complicated life cycle. 14 chromosomes and 5,300 genes in Plasmodium falciparum. So it's a pretty tough adversary. So we're going to be looking here at the asexual cycle. This is the bit that's making us ill. These bits, that's prepare a multiplication stage in the liver. That's a dormant stage with vivax and ovalia, but this is what's going to make you ill. So Plasmodium falciparum on a thick film. You see that at 3 in the morning on call, you're going to be a bit scared. And that's the thick film. And this Professor Kettle might have met the odd one of these because this is post-mortem, of course, cerebral capillaries, and each of those dark blobs is a schizont with pigment of Plasmodium falciparum. So malaria reference lab, what do? We write the prevention guidelines. We have a special line for prophylaxis queries. We do reference diagnosis with all the modalities you'd imagine, microscopy, dipsticks, molecular assays, and surveillance, which I'll come to towards the end. And for those of you who are from haematology, the British Society for Haematology guidelines were written by Barbara Bain, who's a legendary professor of haematology morphology, Claire Rogers, who's a wonderful microscopist, there's me and the other equally excellent haematologists. The game changer came in 2010. Until 2010, in an endemic area, fever was malaria, and you gave treatment. That's guesswork, isn't it? It offends me, it always has offended me, that if you're a febrile patient in a malaria endemic area, you've got malaria, come on. So WHO said enough. So you have to confirm with a parasitological diagnosis, either with a dipstick or a blood film or a molecular method if you've got it. But in endemic areas, the dipsticks would have been the main thing. And molecular, you've got PCR, and you've also got a LAMP assay. Now, this is a critical graph in terms of understanding where we are with malaria diagnostics. So percentage parasitemia, 2% in Britain. We're going to be giving intravenous artesunate. Below that, we'll go with oral unless they're very sick. 100,000 parasites per microliter. The dipsticks, I'm going to be talking about product testing, will detect 200 parasites per microliter. That's 0.004. The very best malaria microscopists, provided they've had coffee and chocolate cake and the phone's not ringing, will get down to 5 per microliter. DNA-based PCR, the WHO target for field use is 2 per microliter, and RNA-based is 1,000-fold more sensitive. Now, 1966, the Rolling Stones and the Beatles were at the height of their power, and the King's Road had lots of people in funny flower power attire walking up and down. But my hero from that time is Professor Garnham, whose lab I now occupy, who diagnosed the exerythrocytic cycle of malaria and produced a monograph on malaria parasites. These are watercolours. The Wellcome Trust paid for watercolours. And you can see more in those than you can in photomicrographs because they're all in one plane. And these are Maurer's clefts, which I'll come to in a minute, but can be misdiagnosed. Some people think that's Vivax if the dipstick says falciparum maybe plus something else because of those dots. But those of you who do on-call will know that the toughest case usually comes at 3 o'clock on a Sunday. You've been on Sunday morning rather than you've already been on for several hours. And it's not as if you've got 6 people around you can ask. And supply is an issue. Expert malaria microscopy in short supply, and fatigue is an issue. I did 21 in the malaria reference last week. I still do blood films 1 day a week. And by the 21st, I was beginning to flag a bit, have a coffee and another bun and do it. What about artificial intelligence? Now, any software engineers in the audience come up and take a bow if there were, because this is really fascinating stuff. What is artificial intelligence? It's basically the computers and machines simulate us and how we solve problems. A subfield of that is machine learning, which is where we are with this thing I'm about to show you. And the subfield of that is neural networks, and then you've got deep neural networks and so on. It gets really quite techy. Convolutional neural networks use 3-dimensional data, right? So a malaria parasite is 3-dimensional, isn't it? I mean, it looks flat on the slide, but it's 3-dimensional. And these convolutional neural networks do much better with images than they do with some of the other inputs. So potentially they're ideal for diagnosing parasites. And it's the convolutional layer that matters. So you need an input data, which is coming from the slide, a filter and a feature map. And it can break down a color image into the equivalent, if it was a light, it's RGB, so it can break down the pixels. And then there's a feature detector, which is us in real life, but they've got a computer one. So it moves across the receptive fields of the image. In other words, you with your eyes move across the slide, or you move the slide, and they're checking if the feature is present. And if it is, then it'll flag it up. And it'll say, right, that's a malaria parasite. And it's the same as us. You've been shown it's a malaria parasite, or it's a cryptosporidium, or whatever it is. And then you see it. You've seen it before. It's like stamp collecting, isn't it? You've seen it before. Until you've seen it before, you won't know. You have to be taught. And it's the same with the computer. So what is this one that I'm about to show you? The EasyScan Go system. There's a scanning microscope developed by Motic, but you can use that for digital pathology. It doesn't have to be parasites only. Then I went to Global Health Labs in Seattle, which is funded by Bill Gates, and it's populated in the nicest possible way by amazing boffins. They're just wonderful people with brains coming out of their brains, and interacting with those was really amazing. And they did the machine learning software. And this is it in action. So this is one of my colleagues who was running it. So you've got the slide in there that's stained, goes into the microscope, is automatically scanned. You don't have to do the scanning. Then it comes out with pictures, and it comes out with a report. Beginning to sound good at 3 in the morning. So it's a bright field microscopy, scans the Geim sustained slide, and it'll then tell you what parasite and so on. Then you get a report, estimated diagnosis, Plasmodium falciparum. So it's malaria, P. falciparum, how many there are will give you a parasitemia, what's the white count, that's useful anyway, and then it'll give you a mosaic of images to check. So when we were developing this, I spent hours literally going through multiple thumbnails of malaria saying, yes, it's malaria, no, it isn't. That's a load of crud, that's a stain granule. And we did it, and then we reran the algorithm again, having re-looked at the images till the performance improved. So it's just like training a biomedical scientist or a registrar. You have to reinforce it, and that's what we did with the machine. So this is one we had, and it says, yes, it's P. falciparum. It gives you the numbers, gives you a white count, and those are the pictures, and I look at that day. That's malaria without a doubt. So we did a study. We did an EasyScan Go against my very best microscopists, the ones that will get down to 5 parasites per microliter. So a tough test for it, with a PCR to arbitrate on discrepant results. And these were returning travellers at HTD or the Homerton Hospital in London. So how did it do? Well, light microscopy versus PCR, as you'd expect, is 72%, because PCR pick up stuff you can't see, as it were. Good specificity. EasyScan Go, pretty good too, allowing for the increased sensitivity to PCR. specificity okay. An easy scan versus light microscopy, almost there, 88% against our best microscopists, and good specificity. So it's getting close. What about species? We had 99 samples positive by both microscopy and the Easy Scan Go. Manual microscopy, 87 of those were falciparum, 12 non-falciparum, as you can see. And the good bit is this machine learning device correctly reported P falciparum for 86 of 87 of them. So if you've got a trainee microscopist in their first week, this machine will beat them. Won't beat your experienced people, but it's on its way. Now, with the non-falciparum, it can't tell vivax from ovale or malaria, simply because we didn't have enough to teach it. If we had enough, we could, but we didn't. Nevertheless, the WHO, when it assesses microscopists, has a standard slide set that it tests them against. And competence level 1, you've got to get 90 to 100% right in finding them, 90 to 100% right in the species, and your parasitemia within 25% of the true count. Level 2 and so on down there. And this is where Easy Scan Go got to. Really pretty close to the top of level 2, just on the top of level 2 for that parasite and species, but it fell down a bit. It didn't reach the 40 that it would have needed for parasite count, but it could still find them almost, well, certainly as good as a level 2 microscopist. Now, what does that mean in practice? Level 1 or 2, WHO says could train people. So that's pretty good, level 2. It's only the parasitemia where it fell down. Level 1 assist and level 4 are out because they've got, as you can see there, they've got pretty rubbish scores. So forget level 4, but level 1 or 2 can train people. So this machine is a really credible piece of kit. So there's another one that's out there called the MyLab system. I haven't evaluated this one myself, but there's a paper from a few months ago. This is a closed system with a cassette. You put the blood, load the cassette, it does the staining in the machine, and you get a picture in there of course of malaria parasite. So they did a field evaluation in Gondar, Ethiopia, and in Ghana, and combined the results. So for P. falciparum, if it was greater than 200 parasites per microliter, this machine was 94%. But a good RDT will hit 200 parasites per microliter. Density is greater than 20, and a parasitemia of 20 is quite tough for a non-expert microscopist. So it beat their local microscopists. But remember, our machine didn't beat our microscopists. So we're dealing with top-of-the-line, world-class microscopists at the Hospital for Tropical Diseases compared to field microscopists. So it's an unfair comparison. But in the field, which is where this would matter, it actually did beat local microscopy. What that means is this: AI is going to have a future in malaria diagnosis and in helminth diagnosis, protozoal diagnosis. There's no doubt about that, and that's great. But the true role will depend on site, and it's yet to be fully established. So I'll leave that with you as a thought. Just checking my little clock here. So now, till the age of about 12, I had a London accent. I got a part as a shoo-in in EastEnders as a boy actor because I had the accent as a natural accent. Same with Only Fools and Horses. But I often wondered I didn't watch it a lot, but I often wondered when he say Rodney, you're such a dipstick, what he actually meant. And to help me, there's a BBC online dictionary that told me. So a dipstick is a fool. Until COVID, I used to have to explain what a lateral flow test was, but I don't anymore, so I'm not going to do that. Just to remind you that this is antigen detection, okay? So you've got a binding antibody, detecting antibody, you know how they work, and it's antigen detection. The target antigens are HRP2, histidine-rich protein 2, which is only P. falciparum, or PLDH, a glycolytic enzyme, aldolase, glycolytic enzyme. We've got those, but they are different isoforms, obviously, from the parasite ones. And some devices will be HRP2 only, or a pan-PLDH, or a combined HRP2 aldolase or HRP2 PLDH. Many, many products. Trouble is, when they started out, and I've been in this since the very, very beginning of RDTs for malaria, why do they fail? Poor technique, It's tougher than doing a COVID test with a bit of nasal secretion. You've got to get the blood in the well, and you've got to put a few buffers on. Low parasitemia, 0.5 per parasite per microliter. No target antigen, too much target antigen. It's called a post-zone effect. It's like a prozone. Because it's antigen, you have to call it post-zone, but that doesn't matter. Or it's a batch problem. So we were getting dipstick A was good in one country, rubbish in another. Or dipstick A, one batch was good, one batch wasn't good, which is manufacturing. So WHO said, right, we're going to introduce product testing. So I joined the product testing thing back here in 1999 before it happened, WHO meeting in Geneva, and then we worked with them for a few years, and we went live in about 2007 with product testing. What we did, all those red spots are countries that gave us blood of known parasite content by microscopy confirmed by PCR. And then in London, we measured the antigen level. The person who you saw doing the microscope was one of those that did the antigen level. Chin Cheng in Queensland did the characterization, particularly of the HRP2 and 3. And John Barmore's lab at the CDC did some additional characterization. And then they had someone who used to go to sleep at night seeing malaria dipsticks because they spend all day testing them. And that was what formed the product testing. And so we produced a parasite detection score. So this is parasite detection score out of 100. It's not sensitivity. Green is 200 parasites per microliter, purple is 2,000. So if you're going to buy up here somewhere. Even here it will be okay. But you're not going to buy there because that's a false positive rate. So that dipstick in this room, 3/4 of you will be told you've got malaria. So that's why we have product testing. And that's the same for P. falciparum. Large number of products, and the star up there means it could detect in addition to P. falciparum. So up here you'd be very safe with any of those. And that's how we met what came to be known as the weird Peru samples, because Sophie Jones, who is now at CDC but was working with me, said, Peter, we've got these Peru samples, they're P. falciparum, they've got no HRP2 in. So what do you do when you get a wrong result? First of all, you repeat it. So they still had no HRP2. They must have got the PCR wrong. So they repeated that. No, they hadn't, because they got no HRP2 or HRP3. They got gene deletions for those. And Sophie filed them in a box labeled to this day the weird Peru sample. Now that's bad if you're out in the tropics. Some countries buy 20 million dipsticks a year. Okay, big stuff. So WHO said if your deletions prevalence is greater than 5%, don't use HRP2 base, you've got to use these. So that kind of surveillance is now in action, and they've already switched or started to switch in Eritrea, Djibouti and Ethiopia. That matters for returning travellers who might pitch up to the hospital next door tomorrow. It's underway in Somalia and Sudan, and WHO says we need to prioritise Senegal, Zambia and Kenya. Kenya's big for safaris, isn't it? Think about it. Now this is what happened in Eritrea. They used a HRP2 LDH dipstick in 2006. 10 years later, there were false negatives, had to ditch it, so they had a PF LDH and pan LDH, but that wasn't sensitive enough on the PF line, so they now have to do two, a pan PLDH and then an HRP2 LDH. So Vivax is going to show up on that as pan, and that'll be LDH will be positive as well. A falciparum deletion is going to show up on that, but not that, and it won't show up on that either because it's Vivax specific. So that's how you find a P. falciparum deletion. It's messy because it doubles their dipstick costs. And what we need is more sensitive LDH detection methods. Now, an example from a non-endemic area that we had in London, just to let you know it's on your doorstep. 72-year-old Sudanese lady pitches up to A&E, back from visiting her family, that's common. She'd had malaria before, I've got it again, okay. Blood-filled malaria parasites, referring hospital, did a dipstick. And reading that dipstick, it had to be non-falciparum. So they sent it to us, and maybe a few Maurer's clefts in the red cells that make it look a bit like Vivax for confirmation. Deletion for both HRP2 and HRP3. So that's a really credible threat to malaria control now, but WHO is on that. But I get lab people ringing me up saying, oh, it's expensive having malaria people on call. We've only got on one call BMS now. We'll do a dipstick in the night and we'll sort it out in the morning. And I said, well, don't, because gene deletion, you're going to miss it. And 12 hours or more for falciparum malaria might be a fatal interval. So don't throw away your microscopes, whether you're doing Helmint's protozoa or blood protozoa, and think about molecular platforms. So all that depends on molecular assays. So if you've got a new analyte coming out, first thing you need is an EQA scheme. So we were asked to develop one for WHO in 2015. It went live in 2017, an EQA scheme for malaria nucleic acid detection. And results, this is from the first few rounds, 200, remember, is the dipstick level, 20 and below, dipsticks and even microscopy again a struggle, so pretty good performance. The blue is with dry blood spots rather than lyophilized. What we do is give them 500 microliters of lyophilized blood, but the field people like blood spots, so they get 50 microliters per blood spot, which means that there's much less going into the PCR mix. Those of you who are into PCR will understand that extremely well. It's always lower with the blood spots than the lyophilized blood, but analyte for analyte in the same quantity, they do very similar. And you can see that here. So there's two things. First of all, dry blood spots didn't perform as well as lyophilized, and the higher above 2 parasites per microliters, the always did better than below 2 parasites per microliter. So that thing about an EQA scheme, if you're going to do it, you need to change practice. And so here we had 46 labs at that time, 31% changed their protocols because of that EQA scheme. Changed protocols or added new methods. Some said, all right, we couldn't see Knowles eye before, but now you sent it to us. We've geared up our assays so we can detect it. And that's an example there. And one added another 3 species. So that's very gratifying. And it's grown. This is the slide I like best of all, because 70% of the labs in our EQA scheme are in tropical countries, 28% in Africa, a quarter almost in Asia, and almost 20% in South and Central America. So that's why we're doing it. We're not doing it to help the Mayo Clinic. They don't need us really, but we've got top-line European and top-line American labs in. But the beauty of this above all is the tropical countries do just as well, which is how it should be. And here's changing performance over time. This is submission numbers. So if you've submitted 11 results, you're one of the points up here. And so we've got lyophilized is the lyophilized less than 100,000 per microliter, that's above, and the same with the dry blood spots. But the trend is always towards improvement. These are smart labs. You have to be smart to do molecular. And the same with P-Vivex, again, a trend towards improved performance, which is, after all, what pathology is all about, going back to Osler. And then combining, we didn't have enough Knowles eye, ovarian malariae for separate graphs, but again, the graph is ever upwards. It's starting to plateau, and that's when you need maintenance, but also you need the very top labs doing remediation for the others. I regard EQA as helpful, never punitive. And by concentration, less than 2 parasites per microliter, greater than 2, the asterisks mean statistically significant. So you always do better with high parasitemia, but that's true of microscopy. And overall, whether it's a blood spot or whatever, dry blood spot or lyophilized blood, dry blood spots tend to lose out because of the quantity, but consistent otherwise. So now we've got ATOP2/3 gene deletions out there, and I've got a call with WHO tomorrow to finalise the arrangements for putting the resistance markers out as well to those labs. That will be a bunch of really elite labs like Columbia in New York or San Francisco where they do it, or London School of Hygiene and Tropical Medicine. But those that want it, it's heading for a lab near them. Now, anybody, it's quite a young audience actually, but until 1956, Britain had one TV channel, BBC. It was BBC, and it was black and white. 1956, ITV came in with adverts, black and white. On a Sunday afternoon, because it was probably a cheap way of filling up the programme, both channels, but especially BBC, would show old films. So I saw all the road movies I mean, this one is 1940, The Road to Singapore, in black and white. My parents, of course, remembered them because they got married in 1936. So they kind of had seen these films in the... And a synthetic hydroxynaphthoquinone attacks the electron transport chain. And that's, plus pyrimidine synthesis, affects how it kills the protozoa. And this, I did my PhD in Wellcome. This was the beautiful blue unicorn. They got swallowed up eventually by a GlaxoSmithKline, so you don't see the unicorn very much, but I loved that badge. And I was the first person to treat human malaria with atovaquone when it was a single agent clinical trial. And we treated them and we got a good clinical response, but the non-immunes recrudesced because you got rapid development of resistance in those with no previous immunity. So then it was decided to add another agent. So proguanil was added. And its parent drug, this metabolite, is cycloguanil, and there's cycloguanil resistance out there. But even if it is present, it doesn't affect the synergy with atovaquone. Quite remarkable synergy. And that fixed dose is used for treatment, but increasingly now it's a very commonly advised prophylactic drug. So I was very proud to be part of the generation of Malarone. Now what about prevention? Okay, how effective is malaria prevention? Insect repellents, bed nets and all that, plus antimalarial chemoprophylaxis, 90% protective or more. Now if I came in today and said, right, we've got a new vaccine, pick me a virus, any virus you like, that's 90% protective or more, you'd snap my hand off and say, right, when do we put it into clinical trial? You would, right? COVID vaccine, RSV vaccine, all the rest of it. But it doesn't quite work like that with malaria, as you'll see. Africa accounts for 94% of the world's malaria cases. That's mind-blowing in itself. And this is impressive data from Malaria Reference Lab that's going to be issued by UK Health Security Agency shortly. I started as director of the MRL 2003, but going back here to about 1985, you'd have 1,500 Vivax, 500 falciparum, but the graph flipped. So now we've got 80% falciparum, a bit of Vivax and not many of the others. And this is the figure for 2023, almost 2,000. We haven't had that for more than 20 years. And here, of course, maybe if we should just have a lockdown, because that was the COVID lockdown. Our malaria case is down to 500. I'm not suggesting it's a good way to control malaria in the UK, but that's what COVID did to us. And visiting friends and relations. Right, this is somebody whose family come from an endemic country. They go back to visit them. So me, for example, Chiodini, Italian name, my grandfather's Italian. So if I go to Italy to see my friends in parasitology there, I'm a VFR, visiting friends and relations. So there's no malaria now, of course, but somebody goes back to Nigeria or Ghana, visiting friends and relations. That accounts for 3/4 of the malaria cases we have. And secondly, this is a disgrace that we are neglecting this population, black African descent, 79% of them who are coming back with this malaria, and it's completely preventable. And if you look at the concentration, 2023, a third went to Nigeria, 15% Sierra Leone, 12% to Ghana. That's 60% of the cases from one country. And here's the tragedy, really, there's no other word for it. Those that travel abroad from the UK, where we know if they took chemoprophylaxis or not, 87% hadn't. Now, people took it, I can reduce our malaria. Why isn't that happening? Well, we've now formed the African Diaspora Malaria Initiative. This is Diana Mabayoji, who was my registrar, now consultant at Barts and Royal London. Pahija Rami Abraham at King's, where I did my training. She's a senior lecturer, and she has Fight the Fakes, fighting fake drugs in tropical country. Amazing scientist. And the Malaria Initiative is a partnership between the African diaspora, led by my two colleagues, and Hospital for Tropical Disease and UK HSA, which includes the Malaria Reference Lab. Why have the previous initiatives failed? Well, first of all, we've got the problem of accessing pre-travel advice, because the diaspora don't access the advice. It's not in a form they find helpful. We write it, I write it. it's full of science, but it's not in a form that is accessible, and it's intended for healthcare professionals. That's the first thing. Every time we have a discussion, same thing, high cost of antimalarials. You're going with a family of 4, that mounts up quite quickly if you're going for a 3-week holiday. Lack of awareness, that people might think, well, I'm not at risk, I lived there, didn't get malaria as an adult, don't need to worry about it. Or they'll just rely on local measures, or they think, well, I've been exposed to malaria before, we don't need protection. Or the family members saying, well, why are you sleeping under a mosquito net? What makes you different from us? And we're getting all these useful clues and input from Diana and Bahija, who understand the issues. So what's different about this initiative? Well, first of all, is we're going to get the DASPA to lead it. So I'm part of it and I'm a partner in it. We get the DASPA Action Against Malaria, whom I've worked with for many years now. We're going to have a community-based resource and hopefully get some implementation. So we're going to have a pharmacy based in a London borough, Lambeth or Southwark. I live in Southwark when I'm in London. A huge amount of malaria there. A local pharmacy. People going to the pharmacy to get malaria pills cheaply or free, we hope, are probably going to buy other stuff for their trip, so the pharmacist won't mind. And then online with social networks. And then provide the health advice tuned to their health beliefs. Because a 90% reduction is a really big prize. And how are we going to do it? Social media outlets, okay? I mean, I always prided myself in having a better iPhone than my registrar, so I could do it better than they could on the ward round. But the point is, all these young ones are twiddling with their thumbs, my sons notably. Social media is the way to get to them. Radio stations and local newspapers and community hubs. The diaspora will take us to the hubs and we will do it that way. So work packages, media, pharmacy, information analysis and community engagement. And that's the our logo which Bahija Amy Abraham designed for us, indicating it's a two-way street. Now, we're coming on now to some milestone cases. And according to my iPhone timer, I'm doing reasonably well. It's so wonderful, these iPhones. Right. So, now, anybody under the age of 40, this is called a record, right? It's made of vinyl, black plastic, and it's got grooves in it. A needle goes round, and when there's dust in it, it crackles. And sometimes it gets stuck, or sometimes it jumps to the next track randomly. So why people still like vinyl, I don't know. Can you take a record player on an airliner, for example, and play it? No, you can't. You need one of these things. But that's what it is. So Shirley Bassey, 1971, Diamonds Are Forever. She's one of the few that did more than one Bond theme tune. And in those days, there was no streaming, there was no internet. So you queued up outside the cinema, and the new Bond film was a big occasion. So she did it for Diamonds Are Forever. Right, so Strongyloides. Humans. So we get infected by filariform larvae from the environment, penetrate the skin. They go round, circulate around, then lung, trachea, pharynx, small intestine, and it's adult females only, parthenogenetic reproduction of females only in the human. Produce eggs that go to rhabditiform larvae out to the environment, separate sexes, mating, eggs, and rhabditiform, then filariform larvae. But also it can go directly from rhabditiform to filariform. The point is, instead of going out, it can also stay in and auto-infect you through the perianal skin or the colon. And then it can build up and up and up. So once you've got it, you keep it 30, 40 years. You don't get rid of it unless you're treated. Duodenal string tests, we don't use them anymore because we could do endoscopies, but this is a furry nylon string. You leave it down the duodenum, 6 hours later you take it out and milk the bile-stained bit and you see the larvae. Numerous Strongyloides larvae in a string test. What can Strongyloides do to you? Well, the most dangerous form, oddly enough, is the asymptomatic one, because that's when you're later immunosuppressed, you're in trouble. Give you diarrhea, malabsorption, larva currens, and if you are immunosuppressed, hyperinfestation. Here's larva currens, urticarial tract. They move, well, a centimetre in a couple of minutes sometimes. They can move quite quickly. So people go to the doctor, they say, I've got this rash, and they lift their shirt up and the rash is gone. Larva currens, if you see that, it's diagnostic. Here's a critical case that emphasises it. 39-year-old Afro-Caribbean male, and then he's got lymphoma, and he has heavy-duty chemotherapy. Neutropenic sepsis, you've all seen that, bleeding, TPN, he's in really big trouble. Then small bowel obstruction, so they do a laparotomy, necrotic lymph nodes, thicken small bowel. Surgeon doesn't know what it is. You wouldn't unless you had the histology. Professor Kettle would have loved this if you were practicing now. And these are multiple Strongyloides larvae going through. That's hyperinfestation. So we cut down his steroid dosage, gave oral ivermectin and oral albendazole, didn't touch it. 12 days later, still viable larvae in the sputum because he's so immunosuppressed. And how well is he absorbing those drugs from the intestine anyway? So I summoned the night nursing officer and we had a conversation with him and his family saying, we've got this veterinary drug, it's not licensed for humans, but really this is something to consider. And said, okay, do it. And we did, and cleared the infection. And that was the first successful report of a subcutaneous ivermectin for Strongyloides hyperinfestation. It's used now as required because we haven't got much else anyway when it gets to that stage. So oral thiabenzazole's horrible. Some patients have said, I'd rather not have the drug and keep the worm, to be honest, doctor. But it's now obsolete. Albendazole's less effective. Ivermectin, rectal thiabendazole's unlicensed. Subcutaneous ivermectin if they're hyper. So the thing is, you don't want to be having that conversation. We're going to give you this drug that's intended for animals because that's all we've got. You really don't want that. So what should happen? Of course, screening, you're all shouting under your breath, why didn't they look for it? So who needs to be screened? Well, the big one is corticosteroid therapy, and the other one is HTLV1 because that predisposes to persistent and hyperinfecting Strongyloides. But all of those can do it, and general debility and malnutrition. HIV and iris is another one. So whole lot. Anybody who's going to be immunosuppressed, who's at risk of Strongyloides, should be screened. Right, so what about the recovery trial for COVID? Steroids. Just compare the symptoms. Severe COVID, cough, fever, dyspnea and diarrhea. Strongyloides hyperinfestation, cough, fever, dyspnea or wheeze, GI symptoms. Can you tell them apart? I can't. Complications, severe COVID, respiratory failure, bacterial infection, renal failure, etc. Pretty well the same for Strongyloides hyperinfestation. So I reckon there were people in recovery trial who died, who might have died with Strongyloides. So we published this, and I'm not going to take you through it, an algorithm, and you can pick it up from the reference there, for those to suspect of having Strongyloides. And then if it was highly suspected, we'd go down this arm and treat them empirically while waiting for the tests. But that's for another day because I've got some more cases to show you, but that's the basis of it. Now, hands up who likes fishing? Fishing must be some, yeah, good, at least one. There's always at least one. Right, beautiful place, Okavango Delta. It's on my bucket list. I've not got there yet, but a lovely place. And this chap went with his mates, 2-week fishing holiday to the Okavango Delta. And they raw bream sushi with lemon. They cut it up, stuck it with lemon juice and munched it up very happily. Great holiday. They really enjoyed themselves. Then when he was back, day one, he's got a serpiginous histaminic tract under his right scapula. He's got this tract coming down his chest wall. Blood film negative for parasites. We always do that because you can have co-infection. Eosinophil counts up. So you're thinking worms, aren't you? Schistosoma, because he'd been around the water a lot. Gnathostomiasis serology negative. And then we thought, well, what is this rash? That's cutaneous larva migrans. It sort of scabs, it's incredibly itchy and it moves slowly. And this is several days worth. You can still see it here on this patient. So then a lesion appeared on this gentleman's face. So he's got this lesion up here. And then he rings up on the phone. Now, bear in mind, my registrar at that time was Chris Van Tulliken of Operation Ouch and the ultra-processed food fame. He was my registrar at the time. And they spoke to Chris on the phone. I just pulled a worm out of my nose and it's wriggling. What shall I do? Now, Chris being Chris said, Google normal saline, because that would preserve it beautifully. And it was still alive when he brought it in. Some people would have said put it in whiskey, but that would kill it off. But, you know, they're tough and they would survive. So that was brought in. And that is Gnathostomiasis. And this is the top. Now, the older ones, hands up those who know what a dental burr is. Yeah. Okay, you're quite young to know what a dental burr is, because before the compressed air drills, they used to have these drills that were driven by belts. And they went quite slowly, and they ground your tooth rather than the high pressure air-driven drill now. And the same with that. It can go where it likes. It can go through any tissue except bone. And it does. It can go into your brain. It can go into... I've seen pneumothoraces caused by it. So that's the anterior bulb there. And these things are like roof shingles, but they've got spikes on them. So it's a fearsome beast. It belongs in felines and canines that eat fish or birds. Pigs are included. And then the egg comes out into a copepod, into a fish, and sometimes into a bird and so on. But we can get it from the copepod, or we can get it from the fish, which is how our patient got it. It was first described in 1836. I went to the British Library and got the original description by the head of the Zoological Society of London, who drew up to the meetings room in Regent's Park. It's still there in his carriage, and gave a paper saying, we had a dead tiger, I dissected the tiger, and in its stomach was a mass, and in the middle of the mass was a worm, and that was Gnathostoma. And it was several years later, 63 years later, before it was described in humans, where there's quite a lot in Thailand. It's emerged in southern Africa now, and in 2008 there was that case that I was involved with, but also South Africa has reported other cases. So plenty of it in South America from the ceviche, so do be careful what you fish for. Now, in the last 8 minutes or so, cystic echinococcosis is truly alien. It's just like Sigourney Weaver. You think you've seen all the aliens, then she does yet another sequel, right? So you've got this parasite that keeps coming back. 24-year-old Turkish lady, blue light ambulance in, arrested in the resus room of a London hospital with an abdomen of that size. They felt her abdomen, lots of lumps. They said, oh, disseminated ovarian carcinoma, gynecology ward. But the SHO on the gynecology ward was the son of the Minister of Health of Cyprus at the time, and said, oh, what about Echinococcus? Good pick. Because look, her entire abdomen, it's a bit dark this, was full of tennis ball shaped echinococcal cysts. And this is her after 2 laparotomies. Now she comes to clinic with her grandchildren. She's absolutely fine. This is how you're used to seeing it. This is a type 2 cyst on an MRI scan. It's like, I always think of it as a balloon full of table tennis balls. That's the radiology registrars will sometimes report cysts, say it can't be hydatid because it hasn't got daughter cysts. That's actually not true. This is a type 2 cyst. Okay? And this is a life ruined. This is a man with an IQ of 168 who I looked after. He was great fun to look after, but he'd lost T11, T12, and half of L1 to Echinococcus in the bone that you cannot cure. You can slow it down. He had Harrington's rods to hold up his spine. Now, I'm going to go on to the histology because this is a histopathologist we're commemorating. That's the protoscolex. That's what's going to infect a dog. That's a germinal layer, which is syncytial, one cytoplasm, several nuclei. That's a laminated layer, acellular. And this produces both those and that. Now, those are the protoscolices. I haven't risked a video, but these were actually moving when we took that picture. A sucker there, they're calcareous corpuscles. And this is the viability test. Red is dead, so we always do the operative specimens. Those are still alive, the others have been killed. Contrast what I'm about to show you on the histology of alveolar echinococcosis. It's not yet endemic to the UK. I was involved in passports for pets, and we were really militant about deworming dogs before they were brought into the country, because we don't want this. It's a liver biopsy. Can anybody find me a hepatocyte in that? There might just, I'd need to go back to the original slide, be one there. But basically, this is all fibrous tissue. And this PAS positive stuff is the laminated layer of Echinococcus multilocularis. Completely different histology, looks nothing like granulosis. And what have we got? Cases we've had now coming in, Eastern Europe particularly, Baltic states. This is one we had that's been resected, hemihepatectomy. Look at all these, it's not a big cyst, it's lots of little vesicles, isn't it? Yeah? They're about 1 centimetre across. That's horrendous. And this one, unfortunately, 23-year-old patient, this is a tragedy. Look at the spleen, huge portal hypertension, ascites. That's across both lobes of the liver, and it's impossible to resect it, and the person simply would not have survived a liver transplant. Came to us too late for that. That is just diabolical. And here, this one here, this isn't a cyst, this is just necrotic liver in the centre. The tumour's around the outside and the centre of it's necrosed. So this one's now been transplanted and is doing very well, I'm pleased to say. So the tragedy is we have got only one type of drug to treat alveolar echinococcosis. Now, going back a few decades, in 1988, I went to my friends at Wellcome. I said, look, Peter, we've got this new drug. It's called azidothymideine, zidovudine, to treat HIV. We're really excited. I said, great. At that time, we had albendazole or mebendazole to treat echinococcosis. Last time I counted in the formula, there were about 30 antiretrovirals, and so there should be, but there aren't for echinococcosis. So that patient, they had the liver transplant, had neutropenic sepsis from albendazole. So that meant that could not be used anymore. So what have you got? You've got salvage therapy with some second-line agents that may or may not be effective, that are case report based only. It really is shameful that echinococcosis, for the cystic, we've got albendazole with adjunctive praziquantel, and for alveolar, we've got albendazole, and that is it. I think that's totally disgraceful. Now, I'm great on succession planning, so I have given up my Hospital for Tropical Diseases lab now, given that to Laura Nabarro, who's there, and Gori Godbally, who's there, and they have both been my registrars, and they're wonderful. So it's an Olympic relay race, and I wasn't going to drop the baton, and I didn't, and they're doing fine. Here I am with them, and that's a wonderful group of parasitologists. I still do Malaria Reference Lab and still do NEATQuest, and we'll do those both for some time to come. So I owe some thanks, HDD, Sophie Jones, Spence Polly, Roxanne, who did the otoscope stuff, Debbie Nolder, Claire Rogers and Colin Sutherland from the London School, Agatha Sayers and Jay Shrivastava from NEATQuest, Barts Royal London, Diana Mabiyoji, and King's London, Bahija, Rami Abraham. So I like to think Professor Kettle would have liked at least some of those slides, and I thank you very much for listening.
Thank you, Peter. That was absolutely fascinating talk, right from telling us all about your own career and giving us some truly inspiring stories about the severity of parasitic infections. And I really hope we've got some inspiration to take back to our labs. I'd like to open out the floor to any questions. Okay, so we have a question from Ed.
So, Peter, your AI methods for malaria, I'm going to just guess that the best microbiologists, the best microscopists are not in Africa, or is that not true?
It depends where you are. So if you go to Kilifi in Kenya, they've got the most sophisticated malaria laboratory you might find on the planet, and they're internationally renowned. But generally, it's a bit like the UK. We have wonderful microscopists in tropical schools, and then in the generality, we have people who've got to do 7 things on call at night who don't have the exposure and don't necessarily skill up. So you'll see there, for example, in that second AI I showed you, where that actually beat the local microscopists. It wouldn't, I don't think, have beaten the people in Kilifi for reasons I've already said. So that's why I said it's site dependent. So I think where this is going is there will be AI machines out there for the generality, because you can put them through relatively quickly and they don't get tired. We're working separately with the University of Westminster to do it for helminths. So we've got AI that can find Ascaris eggs, and we're working on that can find the other helminth eggs. Protozoa are always going to be more tricky, but that's, I think, where it's going.
So my question was going to be then, if that is the case, what does the PPV and the MPV look like in Africa? Because there, where the incidence is higher, for the same specificity and sensitivity, you should by manipulating your data, call it spin, you should actually get a higher performance for the AI in countries that are more endemic. Because positive value also depends on the background levels of infection in the population.
Yeah, you will, but the same will apply, of course, to the microscopist that you're matching it up against, because you've got the same population. You've got microscopists looking at the population that's got X amount of malaria, and the AI looking at it as well. So it will cut across both. That's why say it's got to be site specific. You have to have local microscopists and local AI results to do that.
Any further questions?
Lady there.
Oh, sorry.
So, sorry, we are looking at AI for our own parasitology here. The Apple Core, I think we're looking at giving us a bit of a demonstration.
You're doing tech site, are you?
It looks really good.
Yeah.
And it is something, so it's something you endorse then, and you think it's a good move.
I think it's inevitable, because we had somebody recently who we had trained up in the malaria reference lab who'd been with us 23 years. And of course, somebody like that, it's like the football transfer market, isn't it? You've got a star striker and you're going to buy them up to another lab. And it'll take us X years to get somebody up to that stand again. I think it's absolutely necessary. And I think what will be left in the end is we'll have batteries of these machines and a few elite people. It's like the elite users of a computer system going around saying, oh yeah, that's right. Well, I don't like the look of that. Let's do such a. So no, absolutely go for it, I think. Yeah.
And Karen?
Yeah, I was wondering, there seemed to be a lot of progress in controlling malaria in the 2010s, but I understand that seems to have stalled now. It's sort of plateaued and it's not going so well. I wondered, how optimistic are you about the prospects for control of malaria over the next decade?
Okay, yeah, we were hit very badly by COVID because inevitably resources had to be diverted to cover that. And in some countries in West Africa, the bed net distribution just went down to nothing. And that had a consequence. So what we've got now with the travellers, we're dipping travellers into a much more severe environment, which is how our figures have gone up. And now we're trying to play catch up. And also the world community needs to put in enough funding. It's still not putting enough funding to get the numbers down and to keep them down. And the other thing is, there's an article a few years ago, I got into trouble. It was a dinner at one of the Royal Colleges, and someone said, have you read this paper in the Lancet about getting rid of malaria by such and such? And I said, well, it's going to be very tough. And it was almost as if I'd sort of spat on the carpet. They were really upset that I'd said that. But I've fought malaria for so long to realise that it's probably cleverer than us, and it's going to take a very long time and a lot of money to do it. If you have the United States budget given to every malarial country, of course you could do it. But the reality is they're doing it still on far too insufficient funds, I'm afraid.
And how much impact do you think the new vaccines will have?
Right, that's going to be incredibly useful as part of the jigsaw. Okay, it's not like this new one with possibly higher protective efficacy will be useful. So it's a case of vector control, getting around the insecticide resistance problem, personal protection measures, antimalarials, treatment, case finding, and the vaccination all together. And of course the vaccine in the kids is the crucial thing, because that's where the deaths are mainly occurred. Yeah, it's another useful bit of the jigsaw. Yeah.
For those of us who hopefully will be F1s in a few years' time, what are your words of advice first? When we see an undifferentiated patient, what are the red flags that will make you say, this could be a possible parasitic infection versus a bacterial or a virus?
Okay, right. So undifferentiated febrile patient, the first thing is, where have you been? Now, that question is probably older than me. The late Professor Mike Grace from Liverpool School wrote a paper called Unde Benes, which is, where have you been? And so where have you been and when were you there? So if you, I haven't been anywhere for the last 6 weeks, doesn't do it. You need to know where they've been through the duration. So that, and if they've been to an area where there is potentially malaria, that ticks that box and you're going to look for that. The other thing is, for malaria, is the platelets. We had one recently that had acquired their malaria at an airport, had not left Britain. And that was only picked up because an astute physician, clinical microbiologist physician, looked at the results and thought, well, platelet count, do a film. And a good histostomiasis eosinophil. It's not invariable, but can do, and so on. So, but the main thing is, where were they and what did they do? You'll probably find, I don't know where you are in your medical course, but medicine really depends on the history. If you get the story right and listen to the patient, you're a long way down the road. So take good histories is my bottom line for you.
I think that's a wrap up. So thank you very much.
Okay,
And
my
we just
pleasure.
have one more thing to do, Peter, and Harry is going to take over.
Yes, I'd like to echo Rachel's thanks for an absolutely spectacular lecture, really, really enjoyable. And RCPath have asked me to give you this token of thanks as a memento. So thank you
Fantastic.
very much indeed for coming down.
Thank you very much. That's wonderful.
you.
Thank you all.